So yep. So as Matt said, for those, I think I probably worked with the vast majority of you guys, whether in the ICU, on screens, or in the sim center. But basically, my new role with the residency now is to obviously integrate more point of care ultrasound teaching and training into the curriculum. And so for those of you who have started or already went through sim this cycle around, you may have already seen some of that. But for everyone else, this is going to be the first in probably a series of lectures. For you guys as second and third year residents, most of this should be review. So we'll be able to probably do this pretty quickly and finish early. But that being said, this is via Zoom. It's not the ideal situation in terms of learning point of care ultrasound, but please feel free to interrupt me at any point if something doesn't make sense, if you can't see something. I'm happy to stop, take questions, all right? So with that being said, we'll just get to it. So as most of you guys probably already know, point of care ultrasound, why we like it is because it, can be performed quickly at the bedside in real time as opposed to waiting for other diagnostic tests. And the whole science behind it is that ultrasound penetrates well classically through fluid and solid organs. So, historically, most of the time we used ultrasound for cardiac, abdominal, and GI pathologies. But now, as time has gone on, we've started to find use for it, even with lung pathology as well. That being said, ultrasound does not penetrate well through bone or air or structures filled with air. So we have to keep that in mind. I'm going to use some terms probably periodically. So just when you hear the term anechoic, right? So that refers to something that's back. And classically, that'll be simple fluid on the ultrasound screen. So whether it's pleural fluid, ascites, simple fresh blood, urine within a bladder, things like that. Hyperechoic would be something that's bright whites, whether it's like denser fibrous tissue. And then, back in the day, ultrasound, how we sort of obtain ultrasound has changed. And so the classical method, we actually switched to a different method more recently. So that's why, standard images are sort of used in what's called a B mode. So B doesn't necessarily mean anything. It's just different from the original A mode. So I like to say B is basic mode. So if, when you're using an ultrasound machine and you're trying to get back to your typical 2D echo and you don't see a 2D echo sign, hit the B button and that'll probably take you back to your basic echo. And so that being said, for us, we really mainly just use the two probes that we have that I have up here, right? So this top one is going to be your linear probe, right? So that's going to be used mainly for your superficial structures, classically if you're obtaining peripheral or central IV access. It's great because it's higher frequency, meaning so it has greater perception of structures in more superficial depths. And so outside of vascular and DVT, the only real time I would use this is if we really want to get a close look at the pleural lining to look for lung sliding, which you guys will probably hear more about in the sim session coming up if you haven't gone there already. The other transducer is the one that we use for pretty much everything else, and that's going to be your phased array probe, or body probe is what we also call it. And this is a lower frequency, smaller footprint, but allows for deeper penetration. This is going to be good for all of your other organ systems, so your cardiac, your lung, and your abdominal structures. The other common probe you'll see in the ED or in OB is the curvilinear probe. And so like the phased array probe, the curvilinear probe is better, is lower frequency, so it has greater depth perception. It has a wider footprint compared to the phased array. So it allows you to see more in a single view. That being said, the image quality is not as good. So I tend to not use it, but in the ED when they're doing it, using it in trauma patients for their FAST exam, that's what they tend to use. And so I sort of had this slide up here because there's also, as you guys are getting more comfortable with point of care ultrasound, it's important to understand the terminology because, I don't want to, if I'm watching you try and get views, I don't want to take over for you. I want to be able to describe how to improve your views. And so we use very specific terms to try and let you know how to adjust the probe. So first of all of you guys, when you're holding the ultrasound, you want to hold it like a pencil, and some people hold pencils pretty weird. So I would say, that being said, when you hold the pencil, you want to have, your index finger on top, your thumb below, and then sort of your third, fourth finger is sort of steadying it, right? And then you want to use the aspect along your pinky of your hand, of your palm, to sort of steady yourself as you're moving or moving the probe along the patient's body. And then, so these terms to the right, so anytime we want you to sort of move the probe on the same plane as the body surface, that's called sliding. So whether we want to slide the probe up or down or to the right or left, notice your angle and contact with the patient remains the same. So that's what we call sliding. And that's opposed to something called rotating, where if you're trying to, especially in cardiac views, you want to change the angle of how you're looking at it, so or the plane of how you're looking at it. So you're going to rotate either clockwise or counterclockwise. And then so with sliding and rotating, you're not the probe, the crystals involved in the probe are touching the body completely, as opposed to these terms at the bottom. So tilting is when you're sort of, now you're adjusting the angle by moving the probe itself in relation to the patient's body, either up or down. So that's called tilting. And then from left to right or side to side, that's rocking. And the only reason why I mention these terms is because, especially as you get more experience with practicing ultrasound and have attendings sort of supervise you, we try and use this universal terminology to help obtain the ideal views. Any questions about these terms? So I just wanted to have these two slides coming up. So basically, I wanted to make sure you guys were all familiar with the ultrasound machines that are most commonly used in our hospital system. So has everyone seen this one? These are the ones that you generally sign out of the intensive care unit, right? So these are going to be the stand-up, upright sonocyte machines. And I sort of highlighted the main things to look at and adjust when you're trying to get your views. So with the red circle here, right, we have the top 3 buttons. So the sonocyte's great because it's largely touchscreen. So the top one is your transducer button, and that's going to help you select which probe, whether it's the linear or the body probe, and which presets you want to assign. So if you pick the body probe, do you want to have the cardiac mode or abdomen mode? And then the button below, or the tab below, is going to be the patient button. And so that's going to be where you're going to input your patient data. So you want to input the name, the MRN, you want to put the operator, the supervising attending. So that all goes in that section. And then this annotate tab is going to be important for when you're trying to either write in any image details, if you're trying to remember your image location when you try and review the images later. So that'll be under the annotation tab. These knobs here that I've highlighted in the blue square are going to be the main ones to adjust your image quality, right? So your gain is going to be on the left. And so clockwise will actually increase the gain, so make things brighter. Counterclockwise will decrease the gain. And then if you notice up here, there's gain, and then there's like sort of 3 dots. So the first dot will be total gain, and then there's near or far gain. I would probably just stick with the total gain when you're adjusting the gain. The depth, similarly, so when you're rotating clockwise, that increases the depth. And then if you're going counterclockwise, that'll decrease the depth. And then on the green square, I've highlighted the other things that you will commonly have to adjust. So the camera icon, it's kind of self-explanatory, but the camera icon will be taking a picture or snapshot of your image, whereas the video camera icon, and obviously no one has either of these things anymore. We just have, phones that do both of these, but the video camera icon will record a clip, and it'll depend on the settings of the machine, whether it's 2 cycles up to 6 seconds clip. And then these are going to be your common, your 2D echo is going to be your basic mode of echo. So if you always want to go sort of reset what you're doing and go back to your default settings, you can just hit this 2D echo button. It'll unfreeze the images, it'll get rid of your color, and it'll reset your image or videos. And then this C button is to add color, right? So the color Doppler field to help observe blood flow or direction, and this will be important for any vascular images that you're trying to acquire, if you're trying to rule out whether an IV you're trying to insert is going through an artery or vein. And then obviously it has value in some of the cardiac echo stuff. And then this M, what does this M stand for?
Midline?
M mode.
Yeah, so I heard midline, right? So actually I feel like this is a common misbelief, right? So because the mid, when you hit the M button, right, a line forms down the middle, right? But actually that line can be adjusted, right? So it can actually be moved. So it's not, you hope it's in the middle because we use it commonly when we're trying to put in IVs and things like that. But actually the M stands for motion. So it's actually helps when ideally we use M mode when we're trying to look at an area of interest over time. And so it'll help us look for any changes to that area. So classically we'll use M mode if we're looking at, valvular movement for E-point septal separation, which is a way of looking at LV function. We can look at it for IVC collapsibility. We can look at it for lung sliding. So M actually stands for motion, but you can use it for creating a midline, a line in the middle, but you just have to make sure no one has used it or adjusted the ultrasound machine before you. So this is going to be the most common things you're going to use and adjust on the sonocyte. Does anyone have any questions about anything else, any of the other tabs or buttons that you might want to use? And then notice this is just I got this from like the Sonocyte website. It's just the liver and kidney. We'll get into it, what we're seeing here. The depth, is set to 16 here, right? And normally it'll tell you the time and date, assuming that it's been adjusted accordingly correctly. And then so in the ICU, mainly you'll use, you may have the fellow or attending or one of you guys may use a different ultrasound machine. So I figured I would just show you guys what some of these same buttons look like on the Mindray. So this is going to be the fancier ultrasound machine, the one that looks like a laptop on a stand. So you have a little bit more tools, but also I think they have a keyboard, so it's a lot easier to type things up as quickly as possible. So your main buttons here on the left with the red inside the red circle. So your patient button is going to be where you input your patient data. The probe and exam is going to be where you set your probe and presets. You can help review any saved images or clips by clicking the review button, and then anytime you're done with the exam, you can just hit end exam, and by doing that, the clips and images that you've stored are going to be uploaded to the QPath database. And then so this blue square is going to be your image quality adjustment. So the gain is going to be all the way on the right here. Up button increases the gain, down button decreases the gain. The depth button, the depth tab here is going to be up. It's going to increase the depth, which is kind of counterintuitive, right? Because it'll increase the depth on your screen, and then the down button will make your screen depth shallower. And then you can also adjust the gain by turning this knob as well. And then this B, whereas in the Sonocyte, the 2D echo was sort of your like default reset button. The B button here is going to be what resets your images. And then the other circles to know about is the C, which adds the color, and then the M, which is the M mode button. And then this one, you can also measure more easily, and then using either this button with the measure button, or you can use calipers as well. So that's like basics of like knobology on like what you can do on the ultrasound machines. So I just wanted to run through just to catch everyone up to speed. Obviously this might be a review for many of you who've done the ultrasound elective or rounded in the ICU and tried out ultrasound on the patients. But I just want to run through all the basic point of care ultrasound views. Ideally, once you become very experienced and expert in this, you should be able to, or you could be able to do a full bedside assessment in under 5 minutes. And so that first starts with your cardiac assessment, and in point of care ultrasound, we really have 4 main views. So starting with the first one, this is the parasternal long axis view, and it's called parasternal because it's near the sternum. It's immediately to the left of the sternum. And it's the long axis because you're getting a longer view of the left ventricle. With this, it's important to note where the dot on the probe is. So when you're actually pointing with the cardiac probe using the appropriate cardiac setting, for this parasternal long axis view, you want the dot pointing to the patient's right shoulder. And then, this is trying to show how the structures of the heart that you're actually visualizing. So the right ventricle outflow tract is going to be the most superficial to the skin surface and closest to your probe. So that's why that's going to be the first thing, or the thing that's on top. So this is the right ventricle outflow tract. This is the aortic outflow tract and aortic valve. This here down at the bottom is the left ventricle. And then you see the left atrium over here, and then the mitral valve is separating the left ventricle and left atrium. And so, really, with point of care ultrasound, we're trying to get main things to help us with our diagnostic workup, whether we're assessing a patient in shock and we want to know if is this cardiogenic shock, is this septic shock. So some of the main things we look for in this view is just looking at LV function, right? So is the function reduced? Is it normal? Is it hyperdynamic? And I'll probably go over how to really assess that in later lectures. But we're really trying to get over generalized views of the heart. We're not looking at, certainly you can add color to look at the, for regurg and aortic regurg, mitral regurg, you can do these as some more sophisticated views, but for quick bedside assessment, all we care about is mainly in this view is looking at the LV function and size. And then sometimes, if a patient has like a massive PE, you may see that the right ventricle outflow tract is enlarged, but it doesn't get the full view of the right ventricle in this view. And then, this is not the most ideal view of the parasternal long. I generally like to make it a slightly deeper and see the descending aorta at the very bottom of the screen, because that'll help if we do see, anechoic fluid around the heart. It helps us differentiate whether that's a pericardial effusion from something like a pleural effusion. So that would be the other thing to look out for in this view. So then after we've sort of recorded and obtained our ideal parasternal long view, the next view is parasternal short axis view. So now what we're doing is we're just, rotating our image 90 degrees to get a separate view, mainly of the left ventricle, and comparing it to the right ventricle. So whereas the dot in the parasternal long axis view was pointing to the right shoulder, now we're rotating the probe. We're basically, we want to keep the probe as still as possible on the patient's surface, body surface, and then just rotating the probe clockwise 90 degrees so that now the dot is pointing to the left shoulder. And with this view, you're mainly assessing LV function again. You're also assessing our RV size and function as well in this view. So to truly evaluate the LV function, you want to evaluate it at the level of the papillary muscles. So sometimes by tilting your probe and changing where you're looking at with the left ventricle, you can look at the mitral valve, you can look at the apex, but your ideal parasternal short axis view should have these papillary muscles at basically 5 and 7 o'clock within the left ventricle. And that'll be your most holistic view of looking at the LV function. And notice in normal, and we'll look at clips a little bit later, but in normal LV function and size, you want a nice circular left ventricle. And then your right ventricle will sort of be to the upper left of the screen, and it'll look almost like a crescent shape. And it should be smaller than the left ventricle. If it's larger, or if it's so large that it's pushing in on the septum, that might suggest pressure overload. And then sometimes when that's the case, instead of a nice donut shape, we see sort of a D shape here. All right, so then, once we do our parasternal views, then we sort of move on to the apical four-chamber, and it's called apical four-chamber because we're moving the probe to where we think the apex of the heart is, and then we're angling it up to try and get all four chambers into view. And so in this view, keep in mind, by the way, I think the model's changed, that you should be wearing gloves for all of these, FYI. Yeah, this is just for, your guys' purposes. But so I think, overall, this view should be dominated by the left ventricle, right? Because that should be what's taking up the apex of the heart. And then you want to use this view to compare your left heart structures with your right heart structures. So it's important in this view that you get the you're able to see the lateral wall of the right ventricle, because you want to be able to fully compare the size of the right ventricle with the left ventricle. And then, we'll get into probably this later on, but the right ventricle, you want to be at 2/3 or less the size of the left ventricle. If the right ventricle is larger than that, or if it's equal in size or even bigger in size, that all signifies that the right ventricle might be enlarged. If the right ventricle sort of creeps into the area of the apex, even if it doesn't look overly large, if it creeps into the apex and takes over part of the apex, that's another suggestion that the right ventricle is enlarged. And again, this is another good view for assessing LV function as well, RV size and function, and then seeing if there's any pericardial effusions, which we don't see in this image here. And then if you were to look for something like endocarditis, where you're looking at, I know that was the talk before me, they mentioned something about endocarditis. So if you're looking at the tricuspid valve or mitral valve, this would be another location where you could see a vegetation. You could add color to look for regurgitation. But that would be, as you guys get more comfortable getting these views. And then the last main view is the subcostal or subxiphoid view. And this is another 4-chamber view where we're going immediately below the sternum and then angling it towards the heart. And then the dot on the apical 4 again is pointed towards the left shoulder. Whereas in the subcostal or subxiphoid view, you're changing the angle again slightly to make it more going towards 3 o'clock. And again, this is another way of looking at the right structures of the heart compared to the left heart structures. And then this is an ideal view for also looking if there's any pericardial effusion. And usually we use the liver sort of as an acoustic window to get towards the heart. So your view may be obscured in situations where the patient might have a fatty liver. If they have a lot of bowel gas, you may not be able to get a view here. So those are just some of the things to consider. And then to get, I don't think I had it here, but basically to get your IVC view from here, you sort of just rotate the probe counterclockwise 90 degrees. And then you also change the angle to where the probe is pointing perpendicular to the patient's body. So you're changing the angle of the probe and then rotating counterclockwise 90 degrees to get to the IVC. So that's the basic cardiac stuff. We'll review anatomy and everything in a little bit. Any questions about that? I just wanted to also talk about other organ systems basics as well. So, with the basic lung ultrasound, the main thing we're looking at, right, is this classic lung A-line pattern view where you have your soft tissue above, and then you have your pleural lining is shown up as a bright hyperechoic white horizontal line. And then in normal aerated lung, you're going to have these reflections of the pleural lining, and these are called A-lines. And you can have 2, 3, 4, it depends on the depth of your image. And these just sort of basically are just static repetitions of the pleural line, because below the pleura is air, and ultrasound does not penetrate air very well. And then, when you have a video of the lung ultrasound, you really want to look at the pleural lining for shimmering. So obviously the pleura is made up of 2 different linings, right? So the visceral and parietal pleura. And then with patients' respirations, the pleural lining are sort of, touching one another and sliding up against one another. And so that is visualized by the shimmering up at the pleura. And so that's a sign of normal aeration. If, let's say, when you're looking at the pleura, you don't see any shimmering, the pleura disappears still, that might suggest that there could be a pneumothorax there. So there could be air that's separating the pleural lining from one another. Or it could mean that within that area of the lung, there's atelectasis, so there's no air movement, or so that'll impede on the movement of the pleural lining. Maybe the patient has had a prior pleurodesis from malignant effusion. So there's a couple different things that could cause an absence of lung sliding, but it in the right clinical scenario makes us most worried for a pneumothorax. So as opposed to A lines, B lines are vertical, and they're vertically oriented lines that extend from the pleural surface So up here, and they go all the way to the depth of the image. So if your image is 10 centimeters, your image is 20 centimeters, this bright white line will go all the way down. So that's, you know, when if you're trying to visualize B lines, you're not sure if you see something white, linear, vertical, going all the way down, those are B lines. It's important to know that these move with lung sliding and obliterate A-line pattern. And so because they move with lung sliding, that has to mean in order to see B lines, the pleura lining have to be abutting up against one another. So you will not see B lines in patients who have a pneumothorax in that lung field. So if you see B lines in a certain lung field, that rules out pneumothorax in that lung field. And B lines, you know, classically we think of as pulmonary edema or fluid, but it's very non-specific. And so you have to use it based on the clinical picture. So if there are B lines diffusely and everywhere, that might suggest that maybe the patient is fluid overloaded. If, let's say, there are B lines in a single lung view, it might mean that there's a pneumonia or an infection in that single area. In someone with COVID pneumonia who might have severe ARDS, you might see B lines in all lung fields as well. So it just means abnormal lungs. It doesn't necessarily, you have to still use your clinical judgment and other exam findings to delineate further. Oh, whoops, sorry, I'm going backwards. So the last, you know, I think we'll go over, oh, that's a syndrome. Okay. No, we'll go over more lung ultrasound during your sim sessions as you guys rotate through there in the next couple of weeks. But this is sort of the last view of the lung. And so this is called your Plaques Points, and it stands for posterolateral alveolar and pleural syndrome. And this is going to be your most likely location to where you find pleural fluid accumulating or lung consolidation. And so it's important that you always check this area. This is going to be in the posterior aspect of the lung. So sometimes, you know, you have to go even more posterior than the mid-axillary and just really have the patient sit up and move the probe backwards. And so depicted here, we have the diaphragm. It's shown as the hyperechoic bright white curvilinear structure here. And so anything to the left of it is above the diaphragm. Anything to the right of it is below the diaphragm. So this is probably liver here. And then so this, instead of our typical A-line pattern or even B-line pattern that we're seeing in some of the other images, now this is sort of a consolidated lung. And you can see it actually looks very similar to what a liver looks like. And so that's what we call a lung hepatization or lung consolidation. And there's actually probably a small pleural effusion above it too. You can see a simple anechoic fluid buildup here. And so this is an important area to find, to look for in any of your patients, but especially in patients in the ICU. All right, and then, you know, your basic abdominal ultrasound, you know, is very similar to the FAST exam that they do in the emergency room. The main areas we're looking at is the hepatorenal recess on the right, the splenorenal recess on the left. You can get a view of the IVC and aorta up here. And then you also want to, especially in patients with AKI or altered, you always want to look at the bladder because someone who has a distended bladder, obstructive uropathy, UTI, pyelonephritis, you can appreciate things here. And so this is going to be your nice view of your Morrison's pouch right here, the hepatorenal recess. And then this is a nice normal view of the bladder, of a urinary filled bladder. Okay. And then I just had some quick examples of some abdominal pathology that you might see. So as opposed to the initial view in the previous slide, now you see this is your liver here, right? You see your kidney here, and then you see a sliver of black in between. So for you to have fluid in the Morrison's pouch or hepatorenal recess, it usually signifies that there's probably around at least a liter of fluid in the peritoneal space. So whether that, depending on the situation, if the patient came in as a trauma patient, could it be blood? It's possible. Could the patient have cirrhosis and ascites or SBP? It's possible. So, but if you see fluid here, that's obviously abnormal, and it signifies that there's at least a liter in the abdominal space. Okay, and then this. So what am I showing here?
Hydronephrosis.
Exactly. Yeah. So, right. So you're getting in the center an obliteration of your normal structures, and you just have some anechoic black fluid collection, right? And so this, yeah, is an example of moderate hydronephrosis. And I sort of classically look at like moderate hydronephrosis as someone sticking like a baseball mitt or even like a hand in the center of the kidney. You can imagine these are like little fingers. This is a palm. This is a thumb, maybe, or it looks, I don't know, like some weird animal or seahorse or something. But yeah, so anytime you see black in the center of the kidney, that's abnormal and makes you worry about hydronephrosis. Okay. So the patient, I would then probably look at the bladder or look to make sure it's just unilateral, bilateral. Is the bladder distended? This patient maybe needs a Foley. Okay. So now, we're just going to go through a series of clips, and I want you guys to sort of interact as much as possible. Maybe the less experienced ultrasound gurus, could speak up and work with me to try and figure out what we're looking at here. So first off, just starting off, like, what is this view? What structures are we looking at?
It looks like a parasternal long.
Exactly, parasternal long. Okay, and so what is up here?
RV outflow tract.
Exactly. Okay, what about this structure here?
LV.
Okay, what about this here?
Interventricular septum.
Excellent. All right, what's over here?
LV outflow tract.
Yep, this here.
Aortic valve.
All right, good. What's this?
Mitral.
Okay, excellent. And then, what's this probably down here is the descending aorta. Ideally we would want the depth to be slightly bigger. And then your view of your parasternal long, I generally like to say that I have like your image in thirds. So I want basically a third of it of your depth to be the RVOT, a third to be your LVOT, and then a third to be sort of your mitral valve and LA. Okay, and then what's this structure here? You can kind of make out here.
Pericardium.
Yeah, there's like a little black circle.
Coronary sinus.
Oh
Yeah, which you may or may not see, but it's something to note and point out if you do see it. So yeah, there's a little bit probably a coronary sinus right here in between the LA and LV. Right. All right, good. I will say these clips aren't meant to confuse or trick. All right, so we're going in order. So all right, so what view is this, and then what are some of these structures we see?
This is a parasternal short axis.
Exactly. Okay. And then what is this structure here?
LV.
Okay. And then what's up here?
RV.
Excellent. And then this here?
The septum.
Yep. Perfect. And this is perfect. This is a perfect view for assessing LV function quickly in our bedside POCUS, right? Because we have our papillary muscle sticking out here and here. If you just change the angle of your probe, you can reach up to the mitral valve or even going up to the aortic valve. And then if you scan down towards, you can even look at the apex a little bit more closely as well. A lot of times what I do is I stick my thumb sort of in the center of the image, and then I could helps me visualize if there's any wall motion abnormalities, which I don't really see here. Wow, whoever recorded this clip did it in the middle of the night. Wow, that's impressive. Okay. All right. What do we have? I just ignored us. We're not looking at the spleen, so I don't know why this is there, but okay. But what are we looking at here?
Chamber.
Okay, great. And so what's over here?
RV.
Okay, over here.
RA.
Excellent. Here.
LA.
All right, it's good. What's this?
LV.
All right, excellent. And then what's this valve that we're seeing?
Mitral.
Okay. And then we're not really seeing the ideal, the tricuspid valve tends to be a little bit harder to see. And then how might we want to improve this view?
So we don't see, I think, the border of the right ventricle.
Excellent. Yeah. So I can't really comment, I can try and imagine that maybe it's like over here somewhere. So maybe it's not enlarged, but I wouldn't be able to comment on RV size based on this single view. So ideally, sorry?
maybe if we increase the gain, we might be able to see it, or
It's
no?
possible. It's possible. I think it might, or even adjusting the angle or moving the probe slightly. Maybe there's a rib that came into view or that's obscuring the view. It's hard to say. Yeah. But in this single view, I couldn't comment on the RV size. So I'd probably just stick to addressing the LV function. And then if you change the angle slightly, you might also get what's called a 5-chamber view, where the aortic valve comes into view. It's almost coming into view, I feel like here, but. All right, what do we think about here?
This is a subcostal 4-chamber.
Mm-hmm. And so what's down here?
LV,
All right, excellent here.
LA,
Excellent up here.
RV.
Perfect, and then up here.
All right.
All right, good. Yeah, and so this is another 4-chamber view. Especially, it's important because I feel like a lot of our patients, because of their body habitus, sometimes the apical 4-chamber is hard to get, and they may be, you know, intubated or altered where we can't turn them over on their left side to get optimal view. So this is going to be of increasing importance. And then we would rotate the probe counterclockwise 90 degrees to try and aim for the IVC, especially if we were assessing fluid status. All right, so then with this, I have some 2 clips here. So what do we see over here? So what?
Airlines,
Okay, and why do we say A lines?
Horizontal lines.
Yeah,
There-
so you
yeah.
see this is the pleura right up here,
Mhm.
and then these are the parallel reflections. You see one pretty clearly here, right? And then I'd have to sort of like imagine something here, but I think I see a second A line down here. And then so anytime we see A lines or in any lung ultrasound in general, we want to analyze for lung sliding. So do we see lung sliding here?
yeah,
Yeah.
Yeah, you know, I think there's like a little shimmering, like almost like little spots that are moving around with respiration. So I agree there's lung sliding on this view. And then what do we see here?
also airlines, but there is no sliding, right?
Yep, I agree. So this is the pleura up here, right? And then you actually see quite a few A lines that are just parallel reflections as you go deeper and deeper. And then, yeah, so I think maybe there's some movement of the probe as the clip is going on, but I agree there's no significant shimmering in the pleura. You know, I would say there's no lung sliding in this view. And if you're in doubt, you can always switch the probe to the vascular probe, right? Because the vascular linear probe has better image quality at more superficial depths. So it can really help you pay close attention to the pleura. So I would say if you're in doubt, you can either switch to the vascular probe or add M mode, looking for motion over time over the specific area. And so with absence of lung sliding, there would be very linear lines throughout the duration of your clip. With something like that does have lung sliding, there'd be once you hit the pleura, there'd be sort of just graininess, signifying that there's air going in and out of the lung. That we'll just probably discuss in sim if you haven't gone through the cycle yet. All right, and then what are we seeing in these 2 clips here? So this first one on the left.
A lines with some A line pattern.
Mhm.
So I see the pleura right up here, right? And then there's what, like maybe 1, 2, 3, 4 A lines. And then do we see anything else?
B
See
lines.
multiple B lines.
Yeah. So you see, even though we see a lot of A lines, right, we also see these B lines, right? And so you can appreciate them because they're like vertical, bright white, and they go the entirety of the depth of the clip, right? So you can see them most pronounced over here. And then when we're sort of characterizing is this B line pattern and A line pattern, we really, for us to say, you know, a patient's lying in bed all day, if they might have a small amount of atelectasis in their lung base, it's okay to have 1 or 2 B lines. But once we get past 3, that's probably abnormal. So I would say this is abnormal. This is probably, I would say B-line predominant, even though you still make out a lot of the A lines. What about here?
And it's
Also
not even
B-lines.
proximal PT, it's just distal.
Yeah.
And we know that she.
So you see the pleura up here, right? And then you just see these, all of this sort of is just bright white going the entirety of the depth of the clip, right? So these are just more, this is just trying to highlight the spectrum of B lines that you might see. Whereas like here, you can appreciate more individualized linear vertical B lines. These are more confluent B lines where it completely obliterates any normal A line pattern that you might see. So this in the right picture, if someone who's like very, has significant pedal edema, short of breath, has known heart failure, this might make me worry that they're, if I see this in every lung field, that, you know, they have pretty significant pulmonary edema.
And is that like a long rocket or?
Yeah, so all of these, you know, oh yeah, so B lines, you know, there are lots of different terms, like you can use like rockets that come down from the pleura, you can use spotlight. I personally use spotlights just because it helps signify that they're like sort of bright white. But we use sort of like more linear rockets versus more like confluence rockets. So it's just a matter of whichever terms you guys prefer. But yeah. So I didn't really, and then, you know, so those are just the main quick overview. As we go on with like this academic year, and as you go through the sim lab, we'll get into more detail about individual organ system based ultrasound imaging. So we'll probably, for those who haven't done cycle 2 yet in sim, you guys are going to hear more about lung ultrasound. And then we're hopefully going to be doing some abdominal ultrasound in the spring and maybe cardiac at some point as well. I do just want to mention the benefits of QPath. So for those who don't know, QPath is sort of where all of our images get uploaded once we complete our exams. And it's very important actually because it helps make us accountable for the images that we acquire and interpret. And so it's an encrypted online database. We use it a lot in critical care medicine, and then the ER residents use it a lot as well. But you know, Dr. Shahade has worked on getting everyone within the internal medicine residency, and even I think attending staff as well, access to QPath. So what I would encourage you guys to do is to actually go to the QPath website and try and log in using your webmail user name and password. My guess is you guys can log in, but you may not be able to view exams right away. So if you can view exams right away, then I would just go, you guys should just go ahead and call IT to get full access. And like, why is it important? So if we actually go to QPath image, for example, you know, what's good about it is I can actually review exams with you. So let's say you finish an exam and now you want to view your images, right? Can everyone see my